Okay, so this is a really cool case of chronic exertional compartment syndrome in a firefighter. This was a 51-year-old male with bilateral calf pain for months. It was provoked by activity, for example, climbing stairs, running, and walking long distances. He would typically become symptomatic after a few minutes and occasionally experience weakness and numbness. It did not get better with NSAIDs. Sorry for the typo. No trauma, no back pain, no risk factors or history of blood clots, no discoloration or pallor when he had symptoms. And his past medical history was notable for sleep apnea and diverticulitis. He'd had diverticular disease surgery as well as a biceps tendon repair. He worked as a firefighter and did not smoke and rarely drank. On physical exam, he was well appearing. He was noted to have normal appearing bulky calves bilaterally, which were well developed without erythema. He was centered along the anterior compartments bilaterally, a normal range of motion, normal strength, and a normal neurovascular exam. He had a presumptive diagnosis of chronic exertional compartment syndrome. So compartment pressures were measured and they were done so, which the physicians had him run on a treadmill until he developed symptoms. And then they measured compartments. And in the left anterior compartment, he was 52 millimeters of mercury, and in the right, 48 millimeters of mercury. So let's talk about chronic exertional compartment syndrome. It's essentially an overuse injury seen in young athletic populations, typically runners. It can affect the lower and upper extremity. However, 95% of cases occur in the anterior or lateral compartments of the leg. Running would be the most commonly known risk factor. It is characterized by exercise-induced tightness, cramping, weakness, paresthesias, and pain, which are almost by definition reversible and typically improve rapidly when you stop exercising. Diagnosis is clinical, and meaning that you were very suspicious. However, the confirmation is made by measuring the compartment pressure. On the right side of the scene, you see, on the right side of the screen, you see a description of the pathophysiology of exertional compartment syndrome, which is not well understood, but some combination of increased muscular activity leads to increased intercompartmental pressure, decreased blood flow, impaired perfusion, hypoxia, metabolic derangement, and edema, which kind of creates a feedback loop where the pressure inside the compartment exceeds, to some extent, the ability of the body to pump oxygenated blood into the compartment. Differential diagnosis is broad and includes a variety of stress fractures, medial tibial stress syndrome, which is shin splints, deep vein thrombosis, peripheral artery disease, some tendinopathies and myopathies. Popliteal artery entrapment syndrome would be high on the list in this guy. Fibromyalgia, lumbar radiculopathy, adductor canal syndrome, cystic adventitial disease, and then neuropathies of the various nerves in the leg. They often characterize their pain as severe, localizing to a compartment, and worse with exercise. They may have cramping, paresthesias, numbness, transient pallor, often paresthesias, often reliably occurring with exercise, and increase with intensity and duration, really within minutes of stopping without trauma, and bilateral the majority of time. On physical exam, it is often normal. They may have tenderness, atrophy, or fascial herniation, maybe worse with muscle contraction. And as an example of that, on the right picture here, you have one hand on the anterior compartment of that right leg and the other hand holding it in exaggerated plantar flexion. And then if you ask them to dorsiflex from that position, it may reproduce their symptoms. Diagnosis requires a high index of clinical suspicion. Imaging is useful to exclude other diagnoses like the ones we discussed. And officially, diagnosis is made with compartment pressure measurement, which can be static, meaning a single measurement, or dynamic, which would be before and after provocative activities, which is widely accepted to be a treadmill. There is a non-operative protocol, which you could consider first line. It's going to depend on the patient. First off, modification of running style can be helpful, including more forefoot running. Deep tissue massage to really mobilize those fascial compartments has been shown to help. Activity modification, maybe just run less or do different sports. NSAIDs and potentially Botox injections, however, that can affect muscle strength, which can be a problem. Operative indications include first line for a lot of more competitive athletes who just want to return to sport, and failure of conservative treatment. And then the surgical treatment is fasciotomy, which can be formed open, minimally invasive, endoscopic, among other approaches. On the right side here, you see a nice postoperative wound of a fasciotomy. In the case of our patient, symptoms were getting provoked even when he wasn't exercising. Decision was made to perform minimally invasive fasciotomy, and at 3 weeks post-op, he was doing well, still focused on wound care. At 6 weeks post-op, he was now walking pain-free, and his symptoms had essentially returned to normal. So 3 key points about chronic exertional compartment syndrome is that they are characterized by reversible exercise-induced tightness, cramping, weakness, paresthesias, and pain, typically in the anterolateral compartment of the leg. Symptoms are provoked by exercise and resolve with cessation of activity. And surgical fasciotomy is standard practice, although there are non-surgical approaches.